So our next speaker is Dr. Sarah Bagley. Dr. Bagley is an assistant professor of medicine at BUSM. She's also part of the CARE unit, the Clinical Addiction Research and Education unit, and she's going to be talking about engaging emerging adults in aftercare, in care after non-fatal overdose.
Great. Good morning. Thank you for having me. So I'm going to take advantage of some of what's been talked about before, actually by the commissioner, and then actually also by Dr. LaRochelle. They sort of set up my talk nicely, so I'm grateful for that. And I'm going to talk about engagement of emerging adults in care after non-fatal overdose. All right, so I have no commercial disclosures, but would like to make some acknowledgments. So certainly my mentors and collaborators, which include people both from Boston Medical Center and BU and the BU School of Public Health, as well as the Massachusetts Department of Public Health, because I'm also going to be presenting Chapter 55 data, and then am grateful because I have a Career Development Award as well from NIDA, which gives me the opportunity to have the time to answer these questions. So the first thing that I want to set this up is that, you know, emerging adulthood is a distinct developmental stage. And for those of you who have young adults who are who you care for, either in clinic or because they're your children or your grandchildren, this isn't going to come as a surprise to you, but actually there is this body of literature that has been growing that really has defined this group as a different group. So I'm trained in internal medicine and pediatrics, and in pediatrics we often say that kids aren't just little adults. Well, emerging adults aren't just sort of little adults too. They really are their own group and really do require different care. And how do we know that? Well, there's some brain research. So actually there have been some nice studies that have been done that have shown that brain development continues through the mid-20s. And you say, okay, well, what does that mean though? Does that translate into how emerging adults might behave differently? And the answer is yes, it does. So this age group, you know, it's really defined by identity exploration, self-focus, and sometimes a sense of not belonging. Some of those characteristics are actually really important because it allows them to transition to adulthood, to be able to go to college, live on their own, get those first jobs, you know, finish school, and figure out how they're going to contribute to society as older adults. But some of those characteristics also lead to risky risk-taking, really. And this is why we often see really high rates of alcohol and substance use in this age group. And so I'm going to show you that now. So what we know is that we've been talking about the opioid epidemic. And so the question is, how has it been affecting young people? And so we know that emerging adults, so I'm talking about 18 to 25-year-olds, have the highest prevalence of substance use compared to other age groups. This is true across substances, all substances, except for, I think, methamphetamine. But really, so in general, you can think that they really are the group that are using alcohol and drugs at the highest rates. This is showing past year heroin use, and so this line here, this is 18 to 25-year-olds. And so really what I want to point out is not only are they using at sort of higher rates, have a higher prevalence than these other age groups, but it's also increasing. And this is true too if we sort of, again, look at other opioids, including fentanyl use. And so then the question is, well, what about overdose deaths? Because that's, you know, we've been talking about that today, and we're really trying to figure out how do we start to bend that curve. So this is the absolute number of overdose deaths among people who are under 24, starting in 1999 when we started to see this uptick in the general population. And again, you sort of see this significant increase in overdose deaths among young people. You know, sometimes people will say to me, well, yes, but actually the overdose death rates are higher in 25 to 35-year-olds or 25 to 45-year-olds. And although that's true, we're also talking about prevention here, right? And so if we have medications and treatment that work, we want to actually identify people when they are using at these earlier ages, engage them in treatment so that we start to bend that curve and prevent those deaths that are happening in middle age. So a few more words about emerging adults to sort of drive home this idea that they're different and that they may be experiencing this epidemic in a different way. So they have a lot of high-risk characteristics. So, they've had the largest increase in and prevalence of acute hepatitis C, which is a reflection of, increased injection drug use. When you look at hospital data nationally, there have been increased admissions for infectious endocarditis, again, related to injection drug use, and this is really affecting young people in a different way than it's affecting older adults. And also then when we look at actually once we get them into care, what happens, we also know that they're poorly retained. And so we do have these effective treatments, but they are a harder group. And when you talk to clinicians and people who are taking care of these patients, we know this and we feel this. They are very hard to identify and they're hard to keep into care. As Mark talked about, so medication treatment really is our best option. It's evidence-based, it's what's recommended by our national societies. The evidence is telling us this is the thing to do, is we should be finding these patients and we should be bringing them into care and offering them medication. And this includes methadone, buprenorphine, or naltrexone. But I think that we also know that identifying these patients can be really hard. And so in my clinic, so I'm a clinician investigator, in my clinical role, I run a program for adolescents and young adults in primary care who have substance use disorder. And our biggest challenge is identifying these patients and figuring out what are the right services to offer them to entice them into care. And so although sometimes I might think it should be buprenorphine, that may not be the thing that is the most important to them on that day. And so this is building on the work that Mark has done. And so thinking about, so are there opportunities, though, these high-risk opportunities where we could identify emerging adults and we could try to figure out what is the way that we can find them and then engage them. And so emergency departments, sort of one of these touch points that have been described is one possibility. And so, when a young person shows up to an emergency department, has had a non-fatal overdose, what can we be doing to pull them into some kind of care, pull them into our healthcare system where we do then know what to offer them. And so that's really the question, right? How do we engage emerging adults? And I think, this was really driven, to be honest, from my clinical experiences in caring for these patients, reviewing the literature and seeing there really is this gap in terms of offering appropriate services to this age group. So my approach has really been to first, I think it is important to first describe and understand what is the setting. And so that's the first thing that I'm doing that I'm going to talk about today, which is really determining what is access to medication treatment, that gold standard for opioid use disorder after a young person has shown up to an emergency department with a non-fatal overdose. And then to talk to both people who have experienced an overdose, but then also family members, people who are in the community, to also gain their insight so that we make sure that the interventions that we are developing and implementing actually match the needs of the people who we're hoping to reach, and then to try to pilot that. So again, I'm going to take advantage of the fact that Chapter 55 has been well described this morning, and so those are the data that I'm using. So it's a retrospective cohort study of emerging adults who had a non-fatal overdose in Massachusetts between 2012 and 2014. And so we staggered entry into the cohort, and it occurred when someone had a non-fatal overdose, which was identified through either having an ambulance ride related to an overdose or an emergency department or hospital stay related to a non-fatal overdose. The outcome was the time to medication treatment, again, because this is the gold standard, and then included some other variables. We calculated summary statistics to compare them, young adults to older adults, and then also calculated median time to treatment and fit a Cox proportional hazards model to determine rates of treatment by age group after non-fatal overdose. So we identified 15,281 individuals in that time period between the ages of 18 and 35. The things that I want to point out here are that there are a higher proportion of females in that 18 to 21-year-old age group. That is different. We've talked this morning a little bit about how we sometimes think of young white men, but this is for young people maybe different. Also that among emerging adults, so 18 to 25-year-olds, there's a higher proportion of them who are experienced civil commitment or sort of mandated treatment, which is something specific to Massachusetts. And then also want to point out that overall in this cohort that actually the receipt of any medication treatment in the past year, so buprenorphine, naltrexone, or methadone, was not more than 15% in any of those age groups. So then again, we wanted to look at, well, what's happening after the non-fatal overdose when someone is showing up to an emergency department? And so on the y-axis here is the proportion of people who received medication treatment after the non-fatal overdose, and then we grouped it by these different age groups. You can see the blue bar is any medication, then methadone, buprenorphine, naltrexone. And so, overall, what we see is that, as has been pointed out, is that this is receipt of any medication treatment, again, in these 12 months following the overdose, is lowest among the 18 to 21-year-olds. That they are also the lowest recipients of methadone treatment after a non-fatal overdose. Buprenorphine is the most commonly, that gray bar, the most commonly prescribed medication in the 12 months following. And then, something to talk about here is that in terms of so the story changes with naltrexone. And so actually young people, there's a higher proportion, among those who receive naltrexone, a higher proportion are young people. Then we wanted, again, to look at, well, how long after the non-fatal overdose are people receiving treatment? This idea of timely treatment, we think about this as a really high-risk disease. This is, we've identified this time point. Well, are they getting it in the emergency department or right away? And so really what we find here is no. So this is the median time after non-fatal overdose by age group and then by medication type. And what we find is that actually the median time is not that different among age groups, but it's at least 3 months to any medication after a non-fatal overdose. And then finally, we looked at probability of receiving treatment after non-fatal overdose. And the take home really from here is that 18 to 21-year-olds are less likely to receive methadone after those 12 months after an overdose. And emerging adults seem to be more likely to receive naltrexone. So, so what we feel like we can conclude are that, so fewer than half of individuals in the cohort received medication treatment at any point in that year following an overdose. But the 18 to 21-year-olds had the lowest proportion of treatment receipt in those 12 months. So it's clear, though, that among actually all age groups, there's a significant opportunity, as has been pointed out, to identify these people and then engage them in care, and we're not doing it very well right now. And I think that's something we in general know. We know we're not doing a great job of identifying. We know there are these real gaps in treatment in terms of who has a disease and then who is actually receiving the recommended treatment. What I think is different and interesting and worth discussing is that it actually seems like the kind of medication you receive might depend on your age. And especially as we start to think about, are these medications actually all the same? Are some of them more protective in terms of mortality? It really matters then if we're offering younger people a different medication than older people. I don't think I can sort of conclude definitively from here exactly what we should be doing, but it's raising this question, are we treating young people differently? And that's something that certainly needs further exploration. So as I said, the next step is really to take this, to go out into the community, to talk to people who are working with young people, with their families, with emergency department staff too, to think about how can we be better intervening and working with these individuals to get them into care. And sort of in parallel to that, I think we've been talking, we're in the middle of this crisis, and that the research is really important, but it's also important that we're trying to do things actively on the ground too, because we just can't always wait. And so, we're continuing to refine our clinical model where we actually are using recovery coaches to try to engage people into care and do more outreach and evaluate that program as we go along as well. So I hope I've convinced you that they're different. Emerging adults are different. They're a high-risk group. And that timely access to medication treatment after non-fatal overdose is critical, and that right now we're just not doing it. But then next steps are really, I think someone had talked about qualitative research, is the next step is to really go out and sort of hear from people. What is it that the individuals need, that families need, that communities need, so that we can really try to tailor our work and our programs to the needs of those that we're trying to serve. Thank you.
Thank you, Dr. Bagley. Please.
Thank you for your remarks. My question has to do with overcoming the stigma that exists both in the treatment community and in the recovering community towards agonist treatment medications. I know that there are an awful lot of treatment providers who are headed by people who are in recovery, who have sort of grown up with this attitude that using methadone or buprenorphine is trading one addiction for another. I know that there are many recovery homes that, even though there's an argument to be made, there's law that suggests that not allowing someone on medication-assisted treatment into a recovery home is actually illegal. Happens all the time. So many recovery homes don't let people in if they're on medication-assisted treatment. And then you have the 12-step community itself, where people come into those looking for peer support and are often basically told they're not quote-unquote clean as long as they're using these medications. So how do we get around that type of stigma to allow for more use of what you characterized as the gold standard of treatment?
Yeah, so great question, and always happy to talk about this, actually. So we actually just had a case series accepted where we're describing specifically for young people this stigma, this idea of using medication treatment with these young people, and this idea of that it's sort of just replacing one drug for another. And I think that is common, and it's certainly a barrier. So, so a few thoughts on that. I think it's similar when we think about the Department of Corrections, and sort of a lot of people are well-intentioned, and so they're coming from a philosophy that this is the right thing to do. And so I think for me, that's personally been important to sort of understand it's coming from a good place. But I think it actually shows that we're talking today about sort of translating sort of, bench research into sort of clinical research. But I think we also have to talk about how do we take findings such as like what Mark has presented and then actually translate it in a way that the public can really understand and digest and doesn't just sound like sort of another scientific report that's coming out. And so, I think that requires some work, and I think it also figures out it's important to find allies in those communities who can help translate those messages, because I think sometimes I don't necessarily think, for example, I'm the right person to be giving that message, but it's really about partnering with other people who may be sort of more embedded in the community to help make that clear. And I think it's about communication too. I think that we've really, as part of our small clinical program, really made an effort to outreach to some of these programs where we've had challenges, I will say, in terms of sort of what we thought the right treatment plan was versus what they thought was, and really by opening up sort of lines of communication and trying to do it in a respectful way, we've been able to sort of slowly chip away, I think, at some of that stigma, at least on a small scale.
Ben?
Thanks, Sarah. It was a great talk. This question sort of bridges the two talks. Where do you think we are currently in the story about naltrexone? Because there's been some concerning but non-conclusive data that have been presented by Mark, and now your data that a lot of kids are going on to naltrexone. And what type of data do we need to answer the question?
To answer those questions. Great question. And if Mark wants to pipe up, he can as well. So I think we still don't, to be honest, I think we still don't know, right? Like there have even been some studies that have come out recently that have been in more favor of naltrexone, or showing some benefits. And so it is sometimes difficult, I think, to reconcile. I think one question that Mark raises, this idea is naltrexone maybe right for some groups of patients, and then for other higher risk groups of patients, maybe it's not the right medication. Maybe we really do need agonist treatment with methadone or with buprenorphine. And so, I think I would be interested in sort of more studies, sort of, RCTs looking actually and understanding, stratifying by risk then what happens in terms of outcomes, and following people long enough so that you actually see if they, not for 12 weeks, but really being able to follow them over time so that you could see what happened in terms of their mortality risk.